to start off with an important point. When we talk in our clinic about the baby not gaining enough weight or so forth, we actually talk about it somewhat differently. We talk about the baby not getting enough from the breast, because that's often the problem, that the mother has sufficient milk supply, but the baby's not getting it for some reason. That's just a point, it's a philosophical point. I'm not going to discuss that particular issue. I mentioned it already in the previous talk, where a mother can have lots of milk, but the baby doesn't get the milk that's available to him. Again, I just want to remind you that these are links, so that if you have the PowerPoint and you're attached to the internet, then all you need to do is click and you will get more information. Sometimes it's a blog that we've written and it's on our website, and it's basically a much shorter thing that you can show to mothers. You don't have to open up a whole PowerPoint. And this is our website. Okay, so I've already gone through this and said, I'm not too sure. Can you access Amazon here? It's Amazon.com or Amazon something else? You use the US, okay, great. Both? Anything, okay, all right. So, again, my contact information and some of our information available. Okay, the baby who's not getting enough from the breast. Now, we see this a lot. I'm sure you see it a lot. I think that we can say that the reason most mothers are having difficulties with breastfeeding and babies getting enough from the breast has to do with our modern society. That, 1,000 years ago, very few mothers had problems with breastfeeding. I'm guessing, I wasn't there. But it is important to understand that what has changed is modern society. And requirements, of mothers getting, all sorts of interventions during labor and birth, requirements that babies need to gain such and such amount of weight. And I think that in tribal societies, I don't think that not enough milk from the breast is a new problem completely. It's a new problem in the quantity of mothers that are having difficulty, but it's not such a new problem. And I would think that what happens in tribal societies is that when a baby wasn't getting enough from the breast, mothers would share the baby and give the ones, the ones that are breastfeeding, would give the baby some milk from the breast as well, and everything turns out to be okay. Supplementing with formula is not all there is in the repertoire. I think that we've already talked, and it's obvious that it's the same here as it is in Canada, that, your baby's not taking enough, here is, formula, just give top-ups. Sometimes they actually tell them to stop breastfeeding altogether, as if some breast milk is worse than none at all. So, are there some women, and this I think is a very important question, are there some women who really cannot produce all the milk the baby needs? They get off to they have their birth, they birth at home, they have no interventions that interfere with breastfeeding, and yet they don't have a baby who is gaining weight well. And I think that this is definitely the case. I mean, a friend of my son's, she also had this problem. She gave birth at home, never had any supplements, but she I'll show you her picture. Okay, are there some women who cannot? Yes. Just as some people do not produce enough thyroid hormone or not enough insulin, some mothers really cannot seem to produce all the milk the baby needs. But why should these mothers not breastfeed? And again, I think the real question is breastfeeding much more than breast milk? And I feel yes, absolutely. Breast milk is much more than just breast milk. I think that when mothers feed babies express milk in a bottle, both the babies and the mothers, looks like it's on. Oh, you're just going through. Okay. Where was I? Yes, when mothers express their milk and give it to the baby in a bottle, I think that both the baby and the mother are losing something. There is much more to breast milk than breast breastfeeding than breast milk. And breastfeeding is an intimate physical and emotional relationship between two people who are usually very much in love with each other. Isn't that nice? I mean, it's nice. We sometimes act, I've already mentioned this, as if some breast milk is worse than none. You don't have enough milk to just switch to formula, and that we hear too often. Okay, the following photo, the mother had significant issues in the first few weeks. The baby was not gaining weight, apparently. With good hands-on help, the baby learned to latch on well and get milk well, and the baby started to gain weight. No supplements were ever given, no galactagogues were ever used. And the photo shows that breastfeeding is more than milk. And here's the same baby when he's 2 years old. Not the great latch for 2 years, but okay, I understand that 2 years they don't have to latch on so well. Okay, now I think that it's true that some mothers produce more than others. It's the way it is. I mean, you expect that really when you think about it. That some mothers produce lots of milk, some mothers produce just enough milk, and some mothers produce not enough. Okay, the vast majority of women could produce all the milk that the baby needed if they got off to a good start, etc. But most could produce enough for twins. However, difficulties producing milk are caused by environmental factors. So, for example, labor and birth practices, etc. We've already talked about it. Poor latching on, tongue ties, nipple shields, and so forth and so on. And sometimes some poor advice. Okay? So, feed the baby on just one breast at a feeding. And breast reduction surgery. I don't know how common that is here. I don't think it's particularly common in Canada, but it does exist for sure. Pardon me? Augmentation. As long as they don't do a peri-areolar incision, it probably does not interfere with breastfeeding. But when doesn't matter why they do a peri-areolar incision, it always causes problems for breastfeeding.
Yeah, actually, with my experience, because the culture we are living in, we have too much augmentation and reduction. There is no problem with the augmentation like the reduction. Breast reduction, they always have a problem.
But some surgeons will do an augmentation with an incision around the areola, which I think is crazy. Okay, so here's a mother who is not producing enough milk. The reason she's not producing enough milk is that the baby is an adopted baby. And she is supplementing with a lactation aid at the breast. And you can see the baby doesn't mind. It's okay. All right. This is a mother in Burkina Faso where I was working. I should have had, had the baby. I was just taking pictures for interest. But now I realize I should have had the baby undressed. So you can see how nice and chubby this baby is. In spite of the fact that the latch is terrible. And the positioning of the baby is terrible. And the cigarette hold, right. I mean, like if you talk to most lactation consultants, they say, oh, this baby's not doing well. This baby's doing beautifully. And again, it has to do with, does she have a watch? Does she have a telephone to say what time it is? Oh, the app on her phone, right. Okay. This mother had a lot of trouble with breastfeeding. We saw this mother the first time when the baby was 3 months old. The baby was not getting enough on the breast. The mother was supplementing with bottles. We got her to use a lactation aid, and this is the baby at 6 months. And as you can see, the point here is not so much that this worked very well for the mother, but I think you can see that this is a special relationship. And she didn't know I was taking this picture. I got the permission afterwards. Okay. So possible cause of insufficiency of milk supply, breast surgery, already mentioned breast reduction surgery, breast augmentation with the incision around the areola, and any surgery with a peri-areolar incision. Because it doesn't have to be complete. If it's partial, it still may affect the milk supply. A complete peri-areolar incision is a big problem. Less complete ones are a problem, but less so. So it depends on how complete it is. Many women with breast reduction do produce enough milk, but the majority certainly do not. And we had one mother already now it's almost 10 years a mother 10 years ago who had had breast reduction surgery and was breastfeeding twins exclusively for 6 months. Imagine if she hadn't had breast reduction, she could have fed the army. So here is breast reduction, and they do this. There are new ways of doing breast reduction, by the way, which do not involve the periareolar incision. Some do it through the navel. They work a catheter up into the breast and pull out the, whether that helps or not, I don't know. But this they do. They always do the periareolar incision, surgeons, because they think it looks better. Well, I'm not sure this looks better. I mean, you know, besides, that's how my breasts are for. And here's an incision for a biopsy. I mean, look at this. What kind of a biopsy was this? I mean, we'll just take the whole breast off. And this is not the way to drain an abscess. And we have, this is a very bad case, because this mother, a friend of mine, was her obstetrician. And the obstetrician told her, don't let the surgeon do a periareolar incision. And she told the surgeon, and he did it anyway. You know, we always talk about informed consent and that sort of thing. I hope she did too. Okay, so here's what we treat breast abscess. This is a big issue in North America. A lot of mothers get breast abscesses because, why do mothers get breast abscess, by the way? It all comes back to good latching. At the beginning, when the mother has a lot of milk, the baby doesn't have to have such a good latch, and that sets them up for mastitis. So lots of milk, poor latch, set up for mastitis. The more often you get blocked ducts or mastitis, the more your milk can decrease. And then you're setting up for blocked ducts and mastitis because there's less milk. And so the baby pulls away from the breast when the flow of milk slows down before the breast is, in quotes, empty.
So recurrent mastitis and kind of blocked duct is usually due to poor latch?
Everything is due to poor. Okay, so here's how we treat abscess. So I won't read that to you. Okay. So when I wrote this PowerPoint, we had seen over 100 mothers with breast abscess over about 10 or 12 years. All the mothers continued breastfeeding, even on the side of the abscess. One recurrence treated in the same way and did not happen again. And one fistula, which we thought was going to be a fistula, stopped without the mother stopping breastfeeding. And it lasted about 3 weeks, the draining from the breast, until it healed all by itself, even though the mother continued breastfeeding on the same side. Okay, so here is what it looks like. So this mother had an abscess here, obviously. They look with the ultrasound, and then they aspirate the breast, and then they put this catheter in. And here's how it looks a week after the catheter was removed. They will take the catheter out once there's no more draining. And that's what it looks like instead of the huge incision sometimes surgeons will do. So, augmentation, is it really worth it? I don't know. I can't say. I'm a man, and is this on the right much better? Okay. What other causes of milk insufficiency do we have? Well, one of the common reasons, it's not that rare, is that there's a piece of placenta left in the uterus. And the tip-off is passing clots well after you'd expect them, continued bleeding long after you would normally expect it. So think about this, and it comes up, and I don't know if you have this problem here in Kuwait or in the Gulf area, but mothers are eating their placenta. Yeah, they put them in the capsules, and you eat the placenta. And it's supposed to help you with depression, or preventing depression. The problem is, it also helps you from preventing enough milk, to getting enough milk. And the problem is that if the hormones are there, It's like taking the birth control pill and the milk supply doesn't come in. And they always use the argument, well, you know, animals eat their placenta. Yes, they do. They eat it all in the first day. And you know why? They eat it because, you know, if you're a sheep and you're worried about the wolf, then you eat the placenta because the baby is helpless, right? All they can do is feed. They can stand up, they can feed, but they can't run. So if you have a placenta, the wolf knows something, there's a new baby there. It's not because to prevent depression. I mean, seriously. And it's all done in the first day or two. Anyway, enough of that. If the placenta doesn't produce the capsules, if they don't have hormones, then you might as well just eat liver. You know, it's the same. It's the production of the hormones that make the breast believe the mother is pregnant. In other words, if the progesterone and the estrogen don't go down, then it's as if you're still pregnant and you don't have a lot of milk during the pregnancy. Okay, so I've already mentioned that, I know. And some endocrine syndromes, Sheehan syndrome. But Sheehan syndrome in this day and age is rare. We can argue about how all the interventions during the labor and birth can interfere with breastfeeding, but at least mothers don't get shocked and have problems with their pituitary. Severe blood loss, but then some people have said, well, if you can get Sheehan syndrome then from severe blood loss, well, what if you only have some blood loss? That probably causes problems with breastfeeding, and that makes no sense, really. Polycystic ovarian syndrome, very interesting. It seems to becoming more and more common. And maybe this has got something to do with the way we live, what we eat, I don't know. But recently, at least 15% of all women have polycystic ovarian syndrome. It's and going up. And you know, and it's not like what we used to think, that somebody with polycystic ovarian syndrome is heavy and you know, they have a lot of facial hair. We've seen mothers with polycystic ovarian syndrome that are actually quite thin, that have none of the male features that you see with the polycystic ovarian syndrome. So I don't know. Anyway, metformin is a treatment for it, and it actually helps with milk supply as well. The problem with metformin is that it's very hard on your stomach. But they now have new versions that apparently are not. And hypothyroidism. I don't know if this is true. You know, half our patients are taking our hypothyroid. And I don't know why, because I don't know why. But I think if for low thyroid to really cause problems with breastfeeding, it must be very low. And we don't see that anymore, because all of those are treated anyway. So, maternal use of estrogen and or progesterone, the birth control pill, the Mirena IUD, the NuvaRing, all these things are hormones, and they can decrease the milk supply. If you look at what it says on the NuvaRing, I don't know if you use it here, but the NuvaRing is like a ring around the cervix. One of the side effects is swollen breasts, like as if you were pregnant, and that's a problem. And so, you know, I think the WHO or the LAM, rather, lactation amenorrhea method does work, but you got to do it right. If you don't do it right, well, happy birthday for another one. So keep that in mind. And there are ways of avoiding it. I'm not going to go into that. IUDs with slow release progesterone, absolutely. We see mothers within 4 or 5 days of getting the Mirena, the milk supply. Now, they don't know for sure, but by 10 days, 12 days, they're saying the baby's fussy, the baby's causing, you know, it's pulling away from the breast, just like the onset. Topical estrogens, does that make a difference? I don't know. We don't see that many mothers who are on topical estrogens, you know, sometimes for the vagina, sometimes on their skin. I don't know. And insufficient glandular tissue. This is a big diagnosis in the United States. And I'm not convinced that we should be telling mothers that this is a diagnosis, because then there's no hope. At least not today, maybe in 20 years. But there's no hope if it's insufficient glandular tissue. And we should be very careful also of telling mothers this, because I'll come to that in a second. And poor breastfeeding is probably the most common cause of decreased milk supply that we see. So, Yes, what happened?
Can you go back?
Go back where? Oh, no, you mean up. This one.
Yes, about the insufficient glandular tissue.
Yeah.
What did you say about that? That
We shouldn't tell mothers
shouldn't
this.
tell mothers
I don't
that?
think so. It's up to you. But I don't think we should, because what we're saying is there's no hope. You'll never be able to breastfeed.
Not even like mixed feed?
Oh, yeah, they can do mixed feeding, of course. But here, let me show you something. Okay. Here, this mother came to us at when the baby was 2 days of age. And she came because she had sore nipples. And so we fixed the sore nipples, it was easy. But I noticed the baby was hardly drinking. Okay, so we said, okay, come back, we'll see how things are going. And what we saw, I just want to say, what are the signs of it? This notch between the breast and the areola, and a very big areola. And here's her other breast. And you can see it's even more dramatic, right? Oh, pardon me? Okay, so again, the notch between the breast and the areola, and also this very large areola, and if you look at the breast itself, it seems very small. Okay, what does it mean? Okay, so here is the same breast that I just showed you, and here's the mother with this baby, 4 months old, exclusively breastfeeding. Okay? So let's be careful about making this diagnosis, because those breasts that I showed you were hers. And so it's true that the baby didn't seem to gain weight well in the first month, but then just took off. And so if we had said, oh, you've got to supplement, blah, 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 actually we might have said you have to supplement, but she didn't want to hear that from us, so she didn't come back to the clinic, but she kept in touch with our lactation nurse. And you know, she did this because she was Spanish speaking, and the lactation nurse was also Spanish speaking, so we got along together.
So that indentation due to swollen area with ducts underneath, or with the?
I don't know. I didn't open them up. Okay, we don't know, but those breasts are typical of what mothers would be told about. Oh, obvious insufficient breast tissue, but they're not that baby. To tell you how big this baby is, by the way. This mother was about this tall. So this baby is huge.
So managing this case, just observing the baby.
Well, that's not what we were going to do. It's just that she refused to come back to see us. So in other words, sometimes leave things alone. On the other hand, this mother also had very small, thin breasts like that other mother that I saw, but even more so. This is the mother when the baby was 4 months old. So the breasts grew. And she did supplement in the beginning. And you can see she's got the same decrease. But here's her second baby, exclusively breastfed for 5 months, and she started solid food at 5 months, and that's him at 6 months. So it wasn't because he ate bananas that he looks like this. And again, you see, that mother, I wish I had taken her photo. She came to me prenatally. And she came with her husband, who was a high school friend of mine. And I wanted to take pictures of the breast, but I sort of felt, can I take pictures of your breasts? You know, it's a different thing when they're already breastfeeding, and but this was prenatally. I thought, oh no. But anyhow, okay, there she is. There's an exclusively breastfed 4 months. The mother was told that she had insufficient glandular tissue just because of the shape. This is an exclusively breastfed 4-month-old baby. That's her breast, and again, well, because you know there are things you can put your hand between. Is right? In the Jewish Talmud, it's a reason for divorce if you can put your hand between the two breasts. Okay? And these thin breasts that sort of sag, that's another thing that they say. Oh, this is insufficient breast tissue. And that was the baby. Now, this is the friend of my son's.
And this mother really did not produce enough milk. You can see from this breast, right, but this breast looks normal. And the other thing is that she did supplement with a lactation aid, and she breastfed the baby for a year. The baby never got a bottle, and she breastfed. It's wrong to depend only on the weight. I've talked about this before, and then, so I won't go through this again, but I do want to emphasize how important it is to watch the baby at the breast and not look just at the scale. I know you know that. Do we make mistakes? Sure we do. And I've shown you this before. So, the baby doesn't get the milk that's available is a very important piece of information. And I think that the issue is when a mother says, they often say, I have a lot of milk. How do you know you have a lot of milk? Because after the feeding, I'm still full. That's exactly what's wrong. You shouldn't feel full after the breast. And it's possible that all that fullness is breast milk. But if the baby doesn't get it, the baby will not gain weight. Okay? So, again, poor latch, poor advice, feed 10 minutes on each side, that's a problem. And it's usually due to the fact that with all the IV stuff that they get during the labor and the birth, that the baby is not latching on properly. Okay. And the thing is that once milk supply starts to decrease, it's not always easy to make it come up again. And that's why interventions have to occur as soon as possible after the baby is born. In hospital, they do not watch, in our hospitals, we do, the nurses and the lactation consultants, believe it or not, don't watch the baby at the breast. But if you don't watch the baby at the breast, you don't know if there's a problem. And if there's a problem, then you can fix it. And it's much easier to fix a problem when the baby is 3 days old than when the baby is 3 weeks old.
Yeah.
And even easier than if the baby's 3 months old. We have babies that are sent to our clinic who are not latching on. We saw one just the other day, before I came here, 5 months old on a nipple shield. But our lactation consultant got my baby to take the breast. They're brilliant. Okay, so I've already talked about that. But I do want to talk about babies not transferring milk, just a little bit. I know I've already spoken about it, but it's very important to understand that babies don't transfer the milk. It's the mother that transfers the milk. Because if we say that the baby transfers the milk, then all these things that doctors and lactation consultants say about that baby is, if the baby gets so tired at the breast because he can't transfer the milk very well. It's not true. Babies tend to fall asleep at the breast when the flow of milk slows down. That's so obvious. All you have to do is watch babies at the breast, and you know this is true. And this is a lot of the problems with lactation consultants, pediatricians, and all that, is that they don't watch the baby at the breast. Once you keep, as we've done, we're talking about, in our clinic, 50,000 mothers and babies that we've seen over 34 years. Then you begin to realize something. First of all, that you have to watch the baby at the breast. And secondly of all, that babies don't transfer milk. That babies, how to know the baby's getting milk, etc., etc. Anyway, okay. And it's not true, although it's spoken of all the time, it's not true that the mother's milk supply, if it has not increased by 6 weeks after birth or any arbitrary period after birth, that it cannot increase because the prolactin receptors are no longer being formed. Now I know how do you know? Not you. How does one know that the prolactin receptors are not being formed after 6 weeks? Who came up with that number? And it's just an example of how things are said about breastfeeding. But somebody, I don't know, somebody said, I wonder when the prolactin receptors are no longer being formed. How do they know that? It's crazy. This is theory, and our experience seems to demonstrate that it's not really true. You can make the milk supply increase after 6 weeks. So we have a protocol. I know, we don't like protocols, but we sometimes need, for the purpose of teaching, we need to look at protocols. So that step one, get the best latch possible. Sometimes it's not easy to get a good latch, but the easier you start, the better. So, the better the latch, the more of the mother's milk the baby will get. It's simple. Lactation is not so complicated. the better the latch, the less likely the mother will get sore. And if the mother's not sore, she'll put in the effort to make the breastfeeding work. But you know, if the mothers are sore, sometimes they take the babies off the breast, and now we're starting a spiral downwards. Take the baby off the breast. The baby is being fed by bottle, even if it's breast milk. And if it's breast milk, the baby's milk, the mother's milk supply goes down because pumping is not the same as a baby on the breast. So the baby is now, say, 3 weeks old. Baby's been off the breast for 10 days. The mother no longer is sore. She tries to put the baby back to the breast, and the baby hurts her again, or the baby does not get to the breast, does not take it well, or, the worst of all, the baby refuses it. And that happens a lot. If nipples are sore, making the feedings painless will help the mother put the baby to the breast, to put in the effort. And the thing is, too, the less ideal the latch, the worse the situation is. The less milk there is, the more important it is to get the best latch possible and to keep the baby on the breast. A study that should have gotten more attention, this was published in 1992. I know there are people in this room who were not even born in 1992. 1992. There are a lot of people here who were not born in 1922. But anyway, including me. All right, so they call it sucking technique. I don't like the word sucking technique. It's like the baby has to study in school for a while before he can latch on. But what they really mean here is very good. It said that. What happens here? Oh, okay. So in this study, they had two groups that they divided into three. It included only those exclusively breastfed in hospital. Now this is from Sweden. So you know how the breastfeeding situation is or was in Sweden. 97% of all the babies born in the hospital were breastfeeding exclusively. All the babies breastfeeding was evaluated at 4 to 6 days after birth by the same person. Now this is one thing that in those days, mothers and babies were staying in hospital for 6 or 8 days. They don't do that anymore. But now, the investigator divided the group into two. First of all, those that were latched on well, and those that were nipple sucking, she called it, randomly assigned to either latch corrected, all it took was 5 to 10 minutes of instruction. And this is also very important to understand, is that it doesn't take a long time, especially in the first few days, to latch that baby on so that the baby is well latched on. And those that were not corrected, but got the usual advice. Don't give bottles, feed the baby on command, that sort of thing. So, a changeover from breast to bottle within the first month was 10 times more common in the nipple sucking group, that is, not latched on well, than in those with correct technique. And the correct technique are those that had it right from the beginning, and those that were corrected. That's very important. The respective proportions. So at 4 months, they followed these babies for 4 months, and they found that basically those babies that had good latch were still breastfeeding exclusively, or at least mostly, by 4 months. And those that were not had done very poorly. So the respective proportions of mothers still breastfeeding exclusively or partially were 64% versus 96.5 at 1 month, and so forth. It got worse and worse as they went on.
But the number is too small, only 25, 26.
It's hard.
How we can rely on such study?
Because it's true. Because we learned from that, and the experience we've had is the same, that the babies latch on. So, but what their real conclusion here is, it is a striking finding in this study was that it was possible to identify and correct a faulty sucking technique. Again, this is a very poor terminology, I think, in the maternity ward, and thereby improve the mother's chances of the women's chances of exclusive breastfeeding. So, you know, we have this, and this is not the only study that looks like this, but I think it's important that it's much better. Look, I wouldn't mind. When we see mothers who are 4 weeks old, postpartum, and have been having problems for 4 weeks, it's much better to fix the problem then, when they're still in the hospital, or shortly after. Okay, so this is from that study, and I think you can see that this baby is essentially sucking the nipple. And that hurts, and it also doesn't get babies good milk supply. And this baby has got a bit of a reverse, like table latch on, but he's doing better. This is okay, so this is just trying to show, that's me, not the one with the breast, that's me, that's my hand. Just showing what I already showed you, that if the baby latches on to the nipple, you see what he gets. And if I move my fingers back a few centimeter or two, that's what happens. And this is after the feeding. So it's just to show that although the baby was feeding well, that how the baby latches on makes a real difference. Oh, that might be a video. When the baby latches on here, more impressive, no? Okay. And I think this is another video. The mother in this video was only about 12 or 18 hours after birth. Okay, so again, how the baby latches on makes a big difference. So here's how we sort of try to teach to latch the baby on. Okay, so if the mother pushes here, hand underneath the baby's face. Now remember, this is our clinic baby. And so we teach the cross cradle hold, just because we think that it's the easiest way to get a mother to latch the baby on as best possible. Once she's got that, we do encourage mothers to use the regular hold. So,
Would you recommend a football hold for a larger breasted woman?
no, not particularly. Okay, so you see the nipple points to the roof of the baby's mouth, and then the baby comes on the breast, and you can see that he's got that asymmetric latch. Remember why it works?
Yes.
Good. One person said yes. Okay, you teach the others. So this baby has a very shallow latch, and his nose is in the breast. We fixed it a little bit, but it's still shallow. But at least it's asymmetric. And he did drink better in this position. But we never got him to latch on better until we released his tongue pouch. So this is what we're looking at. Chin in the breast, not the nose, covering more of the areola with his lower lip than his upper lip. And this is trying to show the sequence of events. Now this, I don't know how I did this. This is just 2 slides, it's not a video. But isn't that amazing? I don't know how this happened. But anyway, you saw that the mother brought the baby straight on. She didn't sort of flip him around. Okay, I think this should work. So this mother came to our clinic because she had sore nipples and the baby was not getting latched out. And just fixing the latch resulted in her not having pain and the baby breastfeeding exclusively without problem. And the father wanted to do my taxes for me. There, okay. So when you take videos, remember the baby always puts his hand in it. The only problem here is that the baby's lower lip is structured. But he did much better.
Oh, okay, I won't show you that. That's too bad.
The other thing, and you know, you don't need all this technique, but just to show you, if you put the baby to the breast, the way we showed you, the way I just talked about, the mother's hand is automatically underneath the baby's face like a pillow. Not on his neck, which makes the neck, it doesn't work that well, not on whatever areas.
And there's another hand underneath the baby's face.
So we have a protocol. Besides that, get the best latch possible, know how to know the baby is getting known. then the mother at least is encouraged. She knows what to do. A baby's not getting milk simply because he's on the breast and making sucking movements. And I think that this is something that pediatricians, family doctors, and many lactation consultants for that matter don't know. Once the mother knows when the baby is getting milk, she also knows when the baby is not getting milk, and that's important too. She knows that 20 minutes is on each side is meaningless, that 10% weight loss is meaningless, that feeding the baby every 3 hours is meaningless. And then we have some videos that you can see there. And we have, I don't know if I mentioned it, I think I did, but some of our videos are translated, the text is translated into Arabic. So if you go to our website and the mother does not speak English or any other language, then she may be able to. Now I can't speak for the translation. Hey, I don't know. But if someone who looks at them and tells me, oh, this translation really doesn't make any sense at all. I mean, I don't know. I mean, I speak 3 words now. Shukra. And one other that I forgot. Okay, so I can't tell you. And besides, I can't read Arabic, so. Okay, so the step 3 is the use of the breast compressions. Now, I showed you this on the videos. I think it's pretty good. Now, if the mother's doing it right, it shouldn't hurt. Okay, that's very important because mothers, I don't know what they do, but they say, oh, it hurts. We show them how to do it and say, oh, that doesn't hurt. Okay, so I'm not too sure. So when the baby is starting to drink less and less, but before the baby gets sleepy, start the breast compressions, okay? Compress when the baby sucks but does not drink, not when he's not sucking. If you compress the breast when he's not sucking, then, okay, you'll get him to suck. But if you do it together with the baby nibbling to stimulate the breast so that the milk releases, then you get a much better result. So compressing when the baby is not sucking will make him suck, but the mother and the baby work together. She waits for him to start sucking. Young babies tend to fall asleep at the breast when the flow of milk is slow. I think this is very important to understand. They don't necessarily fall asleep at the breast because they're full. They bathe. If the mother is still releasing milk in substantial quantities when the baby's no longer hungry, he'll pull off the breast. So the fact that he's falling asleep at the breast doesn't mean he's had enough. Okay, so this is the mother doing breast compressions.
Doctor,
Yes.
could it mean that he's tired sucking?
No. Absolutely not. Babies do not get tired at the breast. And this is why I keep emphasizing that babies don't transfer milk. Because this is the idea that the baby sucks milk out of the breast is where the idea comes from that babies get tired at the breast. They do not. Do you get tired when you drink from a glass of water? No. Why would you? Right? The milk, the water comes into your mouth, and that's it. It's not an effort. It's not an effort at all. But this is where the idea comes from. Oh, we can't start babies, premature babies until they're 34 weeks because they get tired and they use up a lot of energy. Babies don't use up a lot of energy to breastfeed. They just drink it because it comes to them. It's easy. Just no more than drinking from a glass of water, it makes you tired.
But it's not passive transfer. He has a role to actively transfer.
Oh yes, of course he has a role. And the example that I used before, where the baby's lying on a bed and wakes up, and the mother has a milk injection reflex, well, he did his part, which was to wake up and tell the mother I'm hungry, because the mother is sensitive to this relationship. So when the baby sucks on the breast, he's stimulating the mother to release, or the breast to release the milk. And that, once we think about it in that way, it starts to make sense.
But it's minimal effort. It does not cause the baby to tire.
No, exactly. Exactly. And this is why it's wrong.
Reflex.
Yeah.
What is the premature also?
Why would it be different if the baby's premature?
The muscles are weaker.
Muscles are weaker, you just fell into the trap.
That's what they told us.
Well, I know what they told you, but it's wrong. It's patently wrong. Saw the videos of the 27-weeker? Yeah, you saw the video of the 34-weeker? You saw the video of the 26-week, the 36-weeker who was early almost term baby? No, it's not anything to do with muscles. The baby does his part by sucking, but the mother does her part by releasing the milk. This is how the cardiologists, oh, your baby's got a heart murmur, that's why he's getting tired of the breath. No, he's getting tired of the breath because the flow of milk is slow, because you've been feeding him a bottle, and he doesn't know how to latch on properly. Okay, so this is just showing breast impressions. So, step 4, when the baby is no longer drinking on his own or with compression, switch sides and repeat the process. Don't tell the mother to feed on just one breast at a feeding, so that the baby gets the hind milk. If the baby's not drinking, the baby's not getting hind milk. Please. Okay. Oh, I actually wrote that. All right. A perfect example how theory trumps common sense. And this has got nothing to do with President Trump, because nothing he says makes any sense. Okay, so here's the variation in fat during a single feeding. Now, this is a very old study, but I'm just showing you, first of all, that the first milk actually has more fat than milk a few minutes later. So, but what you're seeing here is the amount of fat in the milk increases in a straight 60-degree angle, more or less. There's no such thing as a non-fat breast milk. They all have some fat. Now, this is not a lot, but then it increases. And this is only 5 minutes into the feeding. And we have a hospital where the mothers are very, very aware. They probably studied 17 books before they had their baby. And then they're told, you know, the baby has to suck for at least 10 minutes before they get the high-fat milk. And you can see how this makes no sense. It doesn't make any sense. So the mothers came to us not really understanding. They got the impression that the milk has no fat, no fat, no fat, no fat, no fat, and then at 10 minutes it shoots up to some amazing number. And that's not the way it works. But this sort of misinformation really interferes with how mothers understand breastfeeding. Okay, so there's no reason, except sore nipples, and that's an important reason, not to return to the first side and even go back and forth several times. And we can see this, and if you watch for the baby drinking, you can see this, that the baby was not drinking at all on the first time. So the mother takes the baby off, puts the baby on the other side. The baby drinks for a while, the mother is using compression, the baby's not drinking anymore. The baby goes back to the first side, and all of a sudden the baby's drinking again. Because one of the things that probably is true is that the mother continues to make breast milk, even if the baby is has breastfed, 10 minutes ago on that side. Sore nipples are a reason to avoid going back and forth several times, but we need to help the mother with the latching on so that she doesn't have sore nipples. That's very important. And I can tell you, our lactation consultants have a lot of experience. They see many mothers and babies every week. They've been doing it, some of them, for 10 years, every week, well, except for holidays. And so, you get the hang of it. You learn how to help that baby latch on so that the baby, A, does not hurt the mother, but also at the same time, the baby gets more milk. More milk ejection reflexes may occur even if the compression doesn't seem to be working anymore. And compression simulates a milk ejection reflex and probably stimulates a milk ejection reflex, right? Two words that are almost the same. But if we had this was a big problem a few years ago. Mothers were told, oh, if the breastfeeding, if latching on the baby hurts, then the baby's not latching on properly, which is true. So take the baby off and latch the baby on again. Oh, it still hurts? Take the baby off and latch the baby on. This is not such a good idea. And anybody here who has had sore nipples, you know it's not a very good idea. So, often the mother, instead of getting one painful latch, now has 5. And 5 times more damage, and frustrated mother and baby. Not a good idea. What you can do when the baby is still on the breast is pull down the chin, that helps a lot. Push the baby's bottom in with the side of your forearm, so the baby's more asymmetric, and that often helps. So you can fix the latch without taking the baby off the breast. Push the baby, oh, that's already done. Okay, pull the baby, okay, done.
Can you please say it again?
You want me to say it in Arabic?
No. Can you say it again?
I have a different accent, you want me.
How could we?
Okay, so,
Push him away a little bit.
okay, wait, stop. Okay, so without taking the baby off the breast, you see your mother's holding the baby like this. But as she's been holding the baby is often, still symmetric. So if the mother pushes here, you see, the baby moves away and becomes more asymmetric. The other thing is you can pull the baby's chin down, and that makes the baby open up wider. So you can take the baby off the breast and get another painful latch, but if you don't take the baby off the breast, you may be able to help the mother without any problems. Okay? Okay, and this is a result of take the baby off and latch the baby on. Take the baby off, latch the baby on. Okay, so step 5 is to use galactagogues. Now, I don't know how well Blessed Thistle and fenugreek work. They seem to work well, but the thing is that, much of how well breastfeeding goes is a bit up here. And so you tell the mothers that this will help. Sometimes it seems to help. Is there any good proof? Even there are some studies that have shown that if you give the mothers fenugreek and Blessed Thistle, they will get more milk when they pump. But that doesn't prove anything. It doesn't mean that this is what made it better. Maybe more confidence, more relaxed, might make a difference. We do use it sometimes. Our lactation consultants love it. And since they do such a good job, I have to say, I'm not going to complain. But 3 capsules 3 times a day each. And now they actually have 1 capsule that has the same amount of fenugreek and Blessed Thistle. So it's not so bad. But these pills are big. It works better. It works best if they do work early in lactation. So even within the first day, if there's any question about this mother not producing enough milk, particularly well in the first couple of weeks. Once you get past the first weeks, we don't know why. I mean, it may be that they don't work so well, but it also may mean that the mother's milk supply has been decreasing over the first few weeks, and so it doesn't seem to work. So this is hot stuff, Malunggay. So I see many Filipinos in Kuwait. So they know all about moringa.
Even in Saudi Arabia.
Yes, but nothing grows here.
We have moringa trees.
You have moringa trees? All right. But I can't go to Medina. It's restricted. Anyway, okay, fine. I have a picture of a moringa tree in the Philippines, but I don't remember what I did with it. Okay, so one of the things that mothers tell us frequently is that the baby is not happy at the end of the day. And we know that mothers seem to have less milk in the evening. But interestingly enough, mothers who will lie down side by side with the baby seems to feed better in the evening, when there's less milk. Now, I don't know, maybe they are getting more milk. Maybe there's something about the sideline position that makes it so that babies are calmer. So, babies who are reluctant to take the breast in the evening because they sense there is less milk often will take it when the mother and baby are lying down. Not always, but often. And so this underlining here is a link to an article that came from France that said that if the milk is less in the breast, then the baby doesn't really want to go there. They know even without going to the breast that there's less milk. It's sort of like the Montgomery glands. I never asked the question, why do we have Montgomery glands? And this work from France said, well, because it attracts the baby to the breast. Oh, so there you are. And I think that this is what something happens when the mother lies down. Maybe there's more release of these.
She's relaxed more, maybe.
Yeah, Yeah, maybe.
Maybe because of gravity.
Because of gravity, possibly. And one of the tricks that some of our lactation consultants use is to lie down with the baby side by side, if you're lying on the left side, not to offer this breast, but actually to offer the other breast. And for some reason, maybe it is
With the
gravity that makes the flow better. Often the baby, instead of fussing at the breast, will fall asleep at the breast. And when the baby falls asleep, or not necessarily at the same time, the mother also falls asleep. And when the mother falls asleep, her prolactin levels go way up, and so, wow. Okay, the mother needs sleep, right? Nobody's gonna say, don't sleep. But if she's lying side by side with the baby, she may actually sleep a little bit, and that's very good.
You were saying something about the lactation goes out or not?
The prolactin,
The prolactin.
yeah, so the prolactin is the hormone that produces milk.
Ah, okay.
So prolactin levels increase during sleep, even if the sleep is interrupted or short.
So if I sleep while breastfeeding my son, I'm gonna have my milk up.
Oh,
Reasons?
you'll wet the whole bed.
Okay. What about lying down or laying down on my
Sure,
back?
if it works, why
Safe?
not? Well, I don't know, we don't usually recommend it, but there's no reason why it might not work. I mean, again, we need to learn a lot about breastfeeding. So try the lying down position. Our lactation consultants will often use the lying down position to, not quite lying down, but leaning back to help the baby latch on. And if it works, so maybe the baby senses, who knows what it is.
I notice actually it works with mother with large breasts.
Which lying side by side?
Yeah, lie back and position.
Oh, the
work
lay
with
back
large
position.
breasts.
Yes, it's quite possible.
Especially if the mother is tired and too exhausted.
So this is an article on attraction of the baby to the breast. I was just talking about this. This is so full of, psychobabble. But if you look at the last one, basically this study demonstrates the first time that exocrine glands situated on the areola of lactating mothers, women, emit volatile compounds that can reliably activate behavioral and autonomic responsiveness in humans. So there's psychobabble. So what they're basically saying is the volatile compounds attract the baby to the breast, and there it is. That's all they needed to say. So, should the mothers express or pump? Now, I am not a keen person for pumping. I think the mothers really don't like it. Maybe they do, but I think that it's hard work for them. It takes up a lot of time, and most new mothers don't have a lot of time. So yes, if the mother is up to it, but the breast compression is like pumping, except instead of pumping into a bottle, you pump directly into the baby. That sounds like more efficient.
But it has to be there when you're expressing.
Nevertheless, it
Now,
usually,
someone else can participate.
well, no, I mean, first of all, the baby is not necessarily getting that milk if the baby is not latched up as well as possible, so the compression helps. I mean, if it's not helping, then switch sides. I mean, we have other things that we're doing. Yes. Okay, so too often, the problem with pumping, one of the problems with pumping is the mother believes that what she pumps is what she's producing. And sometimes the pumps are not that good. Sometimes it just doesn't seem to work. We have mothers who can pump only little bits of milk, and yet the babies are breastfeeding exclusively. And I think that this is important to understand. I know my own wife, was never able to express milk of any substantial amounts, and yet the babies gained weight very, very well. So, so mothers express their milk or pump their milk, they get 5 cc's and they say, oh, what's the point? Yeah. It's not true that pumping tells the mother how much the baby's getting from the breast. Now, it's true that if the baby's got a really bad latch, then the pumping may actually improve, be more than what the baby gets from the breast. I'm not saying it's all one-sided. Too often, feeding the baby and supplementing and pumping is overwhelming. And the mother goes, what's the point? I'm not going to do this anymore. But she should quit pumping, not breastfeeding. And if she has to supplement with a bottle, again, a lot of this pumping has to do with, I want to make more milk, I want to make more milk. No, what you really want to do, you don't know this yet, but what you really want to do is breastfeed. That's what you wanted to do, remember?
You know, there's a trend in social media where moms take pictures of the fridge full of breast milk. And that's causing a lot of moms concern, like, why don't I have that much
Well,
milk
why on
in
earth-
my fridge?
But why on earth are they pumping all that milk when the baby should be at the breast? Here's a quote from one of the mothers in our clinic. Now, this is not made up. Eh? She says, pumping takes away your will to live. So what if it doesn't work, all that I've been talking about? Then you may have to supplement. Now, but if the baby is doing some drinking, maybe we can fix things. Wait a few days, don't rush into it. Remember that video I showed you, the baby who was doing some drinking, but not a lot? All we had to do was wait. It worked, and it can work. That's the difference. Oh, your baby is should have been 4 kilos 75 today. It's only 4 kilos. You need to no. Let's fix the problem, and maybe it'll work. If the baby is latching on, the best way to supplement is with a lactation aid at the breast. I know that a lot of the mothers don't like it, but they don't like it because they're never shown. At least in our situation, here's the tube, here's your bottle. Good luck to you. Have a good life. They need to be shown how to use it. And when they come to us after that, they're often saying, I don't want to hear anything about the lactation aid. And so we have to sort of re-educate and say, okay, use it once a day. It's better than not at all. Oh, you've got it now. It's once a day is working well for you. Okay, try it twice. And you can move on. Why is it better? Because babies learn to breastfeed by breastfeeding. I know that's a radical idea, but it's true. And the mothers learn to breastfeed by breastfeeding. In fact, when we show them the lactation aid, they say for the first time, oh, the baby is drinking. I see what you mean by the pause. The baby continues to get milk from the breast even when being supplemented, which does not happen with the bottle. The baby won't refuse the breast. That's a very difficult thing for mothers to understand. The babies will refuse the breast because they're getting bottles. Of course they do. There is more to breastfeeding than breast milk. I've said that many times. So, from an email, I feel almost invincible nursing. Nursing is magical and makes my toddler so happy. And this is our version of the lactation aid. The total price for this is $2 for the tube. That's, I forgot what it is like in, what is that in KDs? Okay, 1 DR, there you are. Okay, so it works. I put all these Chinese symbols here because these are symbols of well, I forgot them. I used to know. Okay, and there's a baby with using the lactation aid. Now, why does the mother need this lactation aid? It's in the picture. It's in the photo. Anybody?
Sorry?
Why does this mother need to use a lactation aid to supplement this baby? The answer's in the photo. The latch is not bad. Yes, she's had breast reduction. And you can see it. No. It's very unusual to do breast augmentation in our area with a periareolar incision. The one surgeon that was doing it was died. Okay, so you notice there was no tape there. But again, in order for this to work, you need two things. A good latch and the tube in the right position. If it works the way it's supposed to, it's much less time than breast, bottom. That's the same baby, I think. Now what's that? Oh, and here, when you use a tube that's 91 centimeters, the mother can put the bottle on the night table. She can put it between her breasts like this. As you see, we've increased the size of the nipple hole, right? It's much bigger. Okay, and okay, let's see this one, because how much time do we have? Is anybody aware? I think we have, it's almost 6. All right, let's see if we can make it. So this mother got some very bad advice. I can't remember what it was, but even now, the baby is near the end of the feeding. She does some sweet, and actually the baby's still getting some milk, right? You see the pause. But see, this is mostly nibbling now, even though she's been breakfast. So she waits, and even now, late in the feeding, the baby is getting milk. Okay, so now even without the compression, the baby gets some milk. But this is not as good as I would like to see it. And this one here, everything seems right, but it's not right. The baby's not drinking. So the baby can sit there for hours like this, and the baby's not getting much milk. You can see this has been going on now for, I don't know, 10 minutes, 15 minutes. Look at how little formula has come through that tube. That's what so we have to prevent that from happening. The mother's complaining because about, feeding takes an hour and a half. Well, it won't take an hour and a half if we do this properly. And here, one of the big problems, I don't know if this will work here in Kuwait, this mother is in a public place. It's I don't know, I can't remember what it is exactly, but you can hardly tell, right? And here's a mother in a restaurant using a lactation aid. You can hardly tell, right? I mean, you see the bottle, but nobody knows why she's doing it. And I think if the mother is asked, why are you doing it like that? You say, because I'm not producing enough milk, and this is the way I can continue breastfeeding.
Or it's none of your business.
Yeah, that's it. Canadians are very polite. They say, oh, just, that's the way I keep breastfeeding. Then when the other person goes away, it's like, none of her business. Okay, I already showed you this, and I showed you this. And this is not the way. Express your milk and give the baby your milk in a bottle so we know how much the baby gets. Because that doesn't tell you how much the baby gets from the breast. And what's wrong with us? After figuring out how much the baby gets, the baby may not go back to the breast. And who says that the amount the mother expresses is what the baby gets from the breast? A baby breastfeeding well can get more than the mother can pump. A baby breastfeeding poorly will get less. And if the mother can get enough milk from pumping, the baby should be able to get enough from breastfeeding. Help the mother with the breastfeeding. Don't do it this way. If the mother can't get enough from pumping, she will think that she doesn't have enough milk, even though the amount she can pump does not necessarily reflect how much milk she produces. I wanted to update you on my twin boys. Since you were instrumental in our success, they will be 10 months on Monday in our breastfeeding and eating solids. We used to the lactation aid until fairly recently with twins, by the way. Recently with donor milk. They've been fully on breast milk, then started solids at 6 months. They have not had any nursing strikes. Nursing strikes, by the way, don't exist. If a baby goes on a nursing strike, it's because the mother's had a decrease in her milk supply. Remember that if you are a former elementary person, because we talked about nursing strikes, and to me, the nursing strike never made any sense. Why would a baby who's breastfeeding exclusively suddenly stop breastfeeding? And typical of the nursing strike is the baby nursing okay during the night. I think a huge part of that was giving her my milk in a bottle versus supplementing. Yes, that's another reason. At the breast. I applaud you encouraging other women to nurse babies, not just get them milk in a bottle. There's a huge difference, and I definitely see the relationship aspect of nursing as important as the physical health benefits. And here she is with her twins. Okay. I've already mentioned late onset decreased milk supply, so I won't do it anything. I won't talk about this anymore because we only have about 10 minutes now. So again, talk to the organizers of this conference to send you the links for these PowerPoints. As I say, you can use them, you can disagree with them, but don't change them and say it's mine. All right, and also you can get the links. I think that's very important, and it's the same thing with the book. Okay, thank you.
Thank you, Dr. Newman.
So we have 10 minutes for questions.
We do have 10 minutes. Just quick housekeeping item. Certificates are on your way as you go out. You'll find the certificate. The link we'll have available. We'll announce that on our social media accounts. So, and all speakers that allow us to give you their PowerPoints, we'll have an announcement regarding that.
Thank you.
So, but we'll just take permission from speakers, please. So, any questions?
Yeah, please. Sir, we agreed that maybe 27 or 28 scan is something on the breast, and I experienced so. But what about the coordination between suckling and swallowing and the breathing? Is the baby who delivered the preterm at 27 or 28 weeks can do a full coordination between suckling and the breathing and swallowing?
They do it beautifully. There's actually this idea that somehow it's difficult for the baby to breastfeed, that the baby somehow can't coordinate this drinking. It's just not true.
Because as my experience, I'm a nurse and lactation consultant, but most of the pediatricians inside the NICU, they afraid that baby to go on the breast because of the coordination between breathing and suckling and swallowing.
But then you don't worry about the baby drinking from a bottle, do they?
No, they're using NGT.
Yeah, usually.
Usually they are using NGT.
Well, that's too bad, because these babies breastfeed very well. I mean, I showed you some videos of very young babies, including their 27-week gestation baby.
Yeah.
They do it very well.
Okay, last question, if you don't mind. What about scientifically? Is the mother can breastfeed triplets
We have
exclusively breastfeeding for first 6 months?
we have 3 mothers in our clinic who breastfed triplets exclusively for 6 months.
Yes, for 2 years.
This I don't know how far.
I
You
have a
did?
mother.
Oh, you have.
Breastfed triplets for 2 years.
There you are. Triplets for 3 years. For 2 years. But see, once they get to 6 months, they can still breastfeed. It would be nice if mothers had 3 breasts. That would be easier. But, well, they may have one anyway. Yes, yes.
Regarding insufficient glandular tissue, how predictive is the mother's history of not having any breast changes during pregnancy with its relationship to insufficient glandular tissue?
So the question is, how is the relationship between changes during the,
Is
well,
it predictive that if she didn't experience any breast changes during pregnancy, is it predictive that?
there may be some predictive value, but especially after the first pregnancy, frequently breast changes are much less noticeable in the mother. So, you know, it's hard to know. Sometimes mothers say they didn't get it, the changes, but we have had the experience more than once of the father saying, "What are you talking about? Of course you did."
Any more questions?
Yes.
Oh, no, I don't think anybody can hear you.
You're going to hard to find hospitals that support breastfeeding.
It's the same every year.
Yeah, and so you recommend that the mother is released from the hospital as soon as possible.
Yes, yes, in
Because
fact,
they're affecting the mother's ways of nursing and breastfeeding.
of course, and yes, the hospital routines are very bad for breastfeeding. And the thing is that at least in Ontario where I live, the more and more mothers are giving birth at home. And what we can see is that the mothers succeed much better. Now, you cannot make this into a study, because obviously, if they're going to birth at home, they're also very determined to breastfeed. But of course, there are fewer interventions. And so, you know, it's difficult to say, oh, it's all about the hospital issues, but certainly we do see mothers who birthed at home, who got good help with breastfeeding, and still didn't produce all the milk the baby needed. And I think that this is
where I'm coming from, this idea that, some mothers just can't. Now, not all, just because they birth at home with a midwife, our midwives are not particularly well educated about breastfeeding either, so I wouldn't say that's proof of anything, but certainly those babies that are born at home with a midwife often do much better with breastfeeding than the mothers who give birth at a hospital.
Thanks, Dr. Jack. I have an experience with using the protocol for short-term and long-term guidelines and protocol redactation. I did succeed. Nice story with a lot of moms. About fenugreek tablet that you mentioned, fenugreek pills. On your protocol mentions 600 milligram 3 times daily for 3 weeks or until the milk coming. In my country, we have 2 strengths, 250 and 600. Do you think that 250 it will affect if we start with then shift to 600?
I don't know. The problem with herbs is that they're not standardized. So if you get your herbs from such and such a place where things grow beautifully, that you get good, strong
Crops.
yeah, okay. That the contents of the fenugreek are very, are present in large amounts. It may not matter how much you give. 250 in that situation, whereas if the fenugreek is old, it's come from, Tashkent or something, and has been sitting around for a while, it may make all the difference in the world. It may have no strength at all, even though it's 600 milligrams. So I don't know. I don't particularly like the herbs. Partially because they're big pills. I will usually use domperidone. I think domperidone is a wonderful drug, and it has saved the breastfeeding in so many mothers.
Yeah, I have experience with this drug. About the moringa, that also in the last 3 years, we advise the mother to use moringa. In our country, Saudi Arabia and South region, this moringa known years ago, maybe they said more than 50 years ago, but different name. The name is Hasa Alban. So the mother used it for increased milk supply, so many years ago. But that recently they said discovered this as different names as moringa.
Yeah, and in English, or maybe in Filipino, it's also called malunggay. But the thing is that we don't know if it really works. I mean, again, there's no good study that's ever been done as far as I know. And again, I like the domperidone. It's standardized dose. There's
Yes, Dr. Jack.
oh, who's that?
Regarding the minimum weight gain acceptable, because there's a lot of talks about first month we are at 600 grams per month, then another reading saying no, 750, then somebody told no, once it is 25 grams per day and 30 grams per day, there is a conflict. Some people tell no, the weight gain is not good, but there is unfairness to output. Then they are considering to pump and to complete. So whether there is any guidelines regarding what is the minimum weight gain acceptable first month and the second month until 6 months for the full term, no matter the baby.
I refuse to answer. I refuse to answer because I hope that what I talked about today is important. And so I think that we can accept slow weight gain, whatever the minimum is. I think we can accept that if everything else is going along well. In other words, the baby is generally content, the baby is a happy, content baby, the baby doesn't spend his time with a pacifier much of the day or sucking his fingers. I think that we can accept less, we can accept more. And I think we should get away from these minimum amounts. And I think that we need to get away
Oh, there's stop. Evan is saying stop. I don't like even the idea of grams per day, because that baby that I showed you, the baby where we said it's okay to wait, the baby is breastfeeding better, right? That baby gained no weight for 2 days, okay? And then seemed to gain 280 grams over the whole week. But if you look at other babies, it can give you the wrong impression. Because if the baby goes down or stays stable for say 3 or 4 days, you look at the grams per day, it may only be 100 grams a day. But if you look over the week, what you're seeing is this. And so I think that, like, why not say, how many grams per hour is this baby gaining? Why don't you cut it even more? How many grams per second? The problem is that we're missing the point. If we're I don't mind, I'm sorry, I hope you don't mind me saying so. We're missing the point if we say this is the minimum. Because what we're really trying to do, I think, is make the weight gain decent, fair enough, but also make it so it's a happy, content baby. And the problem is, we consider a baby with a pacifier in his mouth content, or sucking his fingers content, or pulling at the breast. This baby, babies do that all the time. No, babies do not pull at the breast because they're content. They pull at the breast because they're not getting enough milk. And so if we look at the behavior of the baby, that's more important than how much baby gains per day, per week, per month. We don't want babies to be losing weight, but I think we still keep in mind the idea that why is this baby not gaining weight? We need to fix the problem, not just to look at the scale. And sometimes we do need to supplement. Sometimes we do. But it should be done with the birth.
Even with the concern of weight gain, the first solution should be fixing the problem with breastfeeding and supplementing.
Exactly.
Trying to fix and working with the mother, and then the last one.
Okay, we're on the same page. Anything else? Or you done?
We know, I'm here.
Oh.
We know how many birth interventions could affect the breast milk production. But what about epidurals? Because many doctors say that it has no effect on the breast milk production.
Which?
Epidurals.
Epidurals, well, they're wrong.
How does this really affect? Because we are having a hard time convincing mothers and doctors that it does have an effect.
Well, because first of all, with all the extra fluid these babies are getting, we have a problem. We have a problem of the baby looking as if they're not gaining in any way because they're overhydrated at birth. And we have a problem with the babies not latching onto the breast very well because the mother's nipples are swollen. And we also have the problem of the babies being sleepy because, again, I sort of mentioned this morning, the fact of the matter is if you've seen babies born naturally or babies born after cesarean section with fentanyl, say, for example, put into the epidural, the babies that are born without the epidural, they come out and they're, where's the milk? I want it now. And the baby who is born with the fentanyl and all that, they're so I think that, these obstetricians, they've never seen a baby born without an epidural. They don't know what it's like a normal birth. They shouldn't be obstetricians if they don't know what a normal birth looks like.
So for how long it would affect the epidural?
Who knows?
Because I had an epidural. I've seen my baby.
Because there are different doses.
It depends. It may depend on which medication they use. It may depend on how much of the medication they use and how long they've been using the medication. Sorry? Yes, and all sorts of things you can mention.
So it may stay for 2 weeks.
Sorry?
It may stay for 2 weeks.
It depends how you think about this. If a baby is not getting milk well from the breast, then they may be sleepy. If they're sleepy, they may not get milk from the breast. It becomes a vicious circle. And so could it last for 2 weeks? Yes. The effect of the medication, possibly, because they did studies on morphine. And the babies had an effect on the morphine for 2 to 3 weeks after birth. Now, fentanyl is not morphine, but they're related. So, I don't know.
What about the antibiotics?
No, antibiotics shouldn't affect the baby.
Regarding the epidural itself, they always
Well,
say
that's
that
different.
it doesn't reach the baby.
They say that, but
and
it's not
that
true.
he goes, and he's delivered very alert. That's true.
Well, again, how much you use, how long you use it, I mean, these all may affect the baby. But the fact that it doesn't get to the baby, that's clearly not true. There are lots of studies that show that it does get to the baby.
Yeah, from the experience, it's impacting the lactogenesis. It's impacting lactogenesis.
Yeah, you have to be careful with that because it's the same process.
Yes.
The baby is sleeping, doesn't breastfeed well. Doesn't breastfeed well, milk supply doesn't increase.
Okay, regarding the baby sleeping while breastfeeding, I know a mother who used to compress the milk to wake him up.
Well,
Is that a good thing to do?
well, what have I been talking about all day?
Okay, I have a question. Another mother used to pump first for like 15 minutes or 20 minutes and then give her breast to her baby. Is that a good thing to
No.
increase the milk supply?
No. Why would you pump before? That makes no sense. You want fast flow. Babies like fast flow. So give them the milk if you want to pump, but if for some reason pump after the feeding, not before. But compression is like pumping.
All right, thank you all.